convey presynaptic parasympathetic fibers, and it will actually merge together with a nerve coming from down here called the deep petrosal nerve. So the deep petrosal nerve and greater petrosal nerve will merge and form a nerve called the Vidian nerve, also known as the nerve of the pterygoid canal. This is important because this nerve of the pterygoid canal will then go to the pterygopalatine ganglion. This is where parasympathetic fibers that have been coming from the facial nerve via the greater petrosal nerve will synapse. And after they have synapsed, they will hitch a ride on a couple of different branches. I'm not going to dive into the details, but it includes branches of the trigeminal nerve and end up going to the lacrimal gland. So, in a nutshell, the facial nerve is necessary to be able to make tears. In addition to that, well, the deep petrosal nerve actually carries sympathetic fibers. These are postganglionic or postsynaptic sympathetic fibers. They have no business in the pterygopalatine ganglion, so they're just going to pass through. But, of course, we will need to have sympathetic fibers reaching the head region as well because of vasomotion, pseudomotion, and pilomotion. So, vasoconstriction, sweating, and your hair standing on end, those are sympathetic functions that have to happen in the head region. Okay. In addition to that, of course, we need to have sympathetic fibers that can travel upwards and even higher and higher up to the orbit, right? Because then actually specifically to the eyeball, because we have some of the muscles that will hold the eyelid open. Yeah? They're actually called little tarsal muscles. And the dilator pupillae, that's the one that opens up the pupil widely when you are wide-eyed, yeah, is a sympathetic response. So we need sympathetics in the head region as well. So let me hide this now. That was the facial nerve. And let's do a little check if the info has been able to seep in so far. Let's review the glands, or some of the glands in the head region. In a nutshell, parotid glands are the largest glands innervated via the glossopharyngeal nerve. Check. Other glands, sublingual, submandibular, and the lacrimal, all innervated ultimately by branches of the facial nerve. Okay? The sublingual and submandibular glands get their innervation after the presynaptic parasympathetic fibers have synapsed in the submandibular ganglion. Okay? So, the prize question would be, if I was to lesion this nerve indicated with a little arrow now, what would be a symptom that you would expect in the patient? Let me give you a hint. The nerve I am indicating, or trying to indicate, is the chorda tympani. I'm only lesioning the chorda tympani on one side. So, if I was to lesion the chorda tympani on one side, I would be lesioning the parasympathetic fibers, but also the special sensory fibers, aka taste fibers in this case. That means on the affected side, if this is the right side, I would not be able to produce saliva from these two glands, and I would lose the ability to taste from the anterior 2/3 of my tongue on the right side. I would, however, still feel it if I bite my tongue, because the sensory afferents, the general sensory afferents that are coming via the lingual nerve, they're still there. They are not affected. On the other hand, to decrease or to prevent tear production, I would actually have to lesion something between the pterygopalatine ganglion and the lacrimal gland, or parts of the facial nerve like the greater petrosal nerve prior to this. Okay, let's have a brief look at the vascular supply of the face. Okay, so if I zoom in a little bit here, here is the facial artery, right? And you might already know that the facial artery is a branch of the external carotid artery. Some people actually might call it the external maxillary artery. However, it arises from the ECA and it passes anteriorly and superiorly over the mandible. Okay, then it'll travel upwards or superiorly along the line of the nasolabial fold in the face. It'll then end by splitting in two or bifurcating into a lateral nasal branch and the angular artery, which should be this one here. As the facial artery crosses over the inferior border of the mandible here, it is fairly superficial. Okay, you can use that to take the pulse at that point. Anesthesiologists, for instance, can take facial pulses when they're standing at the head end of the operating table. And the facial artery has a very, very tortuous course, as you can actually see fairly well here in this animation. And so it'll give off numerous branches to the lips. Those would be labial arteries, this inferior and superior labial arteries, but also to the nose and the chin, and so on and so forth. If you have a profusely bleeding wound in the face, well, it is likely, if this is arterial, that if you compress the facial artery against the mandible down here, that you will be able to help decrease the bleeding because you are occluding the facial artery by pushing against the inferior border of the mandible here. Here's a different view. This is the course of the facial artery all the way coming from the ECA. The veins are usually fairly similar in their course to the arteries. If you think about the course of the facial vein, it is even more superficial than the facial artery. It is a direct continuation of the angular vein that will approximately happen at the level of the inner canthus of the inner eye. So you can see just about here where the transitions between the blue and the pink. Okay, this will receive tributaries from several regions, for instance from your infraorbital, labial, submental, and the anterior jugular veins, and then the facial vein will run inferiorly down the face and curving posterolaterally to then empty into the internal jugular vein, as you can see going along here, and there's your IJV. One interesting thing about this is the facial vein is valveless, right? You might know that in the extremities we frequently have veins that have valves. That's important for the so-called musculovenous pump that helps return blood to the heart. It also prevents that we have like increasingly tremendous high blood pressure. However, the fact that the facial vein is valveless is actually also a problem because, well, that means blood can flow not only away from here, but if you have a clot like thrombophlebitis, for instance, like an infection in the vein that occludes the blood flow, you could actually have, well, via communications with, for instance, the ophthalmic veins, well, you could actually have a route or a potential route for the spread of infection that might go all the way into the cranial cavity. And then you would need an ambulance, as you might be hearing in the background. So now let's briefly touch on the lymphatics of the face as well. Okay, so in brief, what we can say is that except for the parotid or buccal region, there are no lymph nodes in the face itself. So lymph that is coming from your scalp, the face, and the neck will drain into something that is described as the superficial ring of lymph nodes. It's also called the pericervical collar of lymph nodes, right? So there are lymph nodes that are going to be submental, so below the chin, as you can see here. Submandibular, more lymph nodes over here. There are parotid, mastoid, and occipital lymph nodes. They're located at the junction of the head and neck. The lymphatic vessels of the face will accompany other vessels of the face. Okay, so your superficial lymphatic vessels, or superficial lymphatic vessels, will accompany veins, and the deeper lymphatics will be accompanying arteries. All the lymphatics of the head and neck. See if I click on these different ones, here are some parotid lymph nodes, here are some lymph nodes. This is a mandibular lymph node, for instance. All the lymphatic vessels from the head and neck will drain directly or indirectly into the deep cervical lymph nodes, which is this chain of lymph nodes along the internal jugular vein. Let me see if I can add in the IJV again for us here. Lying along here, this is where this chain of lymph nodes is. Okay, these are deep cervical lymph nodes. Okay, so lymph from these deep nodes will then pass to the jugular lymphatic trunk, which joins the thoracic duct on the left side. You should be able to see it right here. That's at the left venous angle. And on the right side, it'll join the right lymphatic. Respectively, this is at the venous angles. So this is the left venous angle for the thoracic duct and the right venous angle where the right lymphatic duct enters. So let's talk about one more clinical correlation. This is called Frey syndrome or gustatory sweating. Some people might also know it under the term of auriculotemporal syndrome. And so this is something that can occur in people who've had a parotidectomy. As a side note, about 80% of the salivary gland tumors are going to be parotid tumors. Okay, so if you excise the parotid gland, well, you still have the fibers that used to innervate it, right? So you have secretomotor fibers that had been going to the parotid gland that do not have a target anymore. So these fibers are then going to search new targets, and these will be sweat glands. So someone who is eating something who will be suffering from Frey syndrome or gustatory sweating, that actually enables you better to tell what this is going to entail. Well, someone who will eat after a parotidectomy might start sweating on the side of the face. Yeah? Because now, instead of the parotid gland secreting saliva as a response to eating, we have the sweat glands being activated. So, when the patient eats, you will see beads of perspiration appearing directly on the skin over the surface of where the gland used to be. So, upon gustatory stimulation, there's localized sweating right there. Okay, and some people, it can be quite annoying. And although this condition is fairly rare, the problem could have an impact on the quality of life. For example, restricting the normal activities such as eating in public. Many methods are currently used to treat it. That'll include, for instance, topical application of anticholinergic agents and antiperspirants. Or you could do an intradermal, so injection into the skin of Botox.